Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Mohammed Talic, and I'm honored to be joined by the one and only, the master Uguay of bone biology, Qusai Hilal.
Hi everyone. Personally, I am more of a matcha guy myself, for stronger bond with milk, of course. On that topic, we are about to make osteoporosis and the medications used to treat it make perfect, delicious sense, almost as good as the matcha I'm totally drinking right now.
Oh boy, we are definitely getting the ball rolling now. Now let us take a case together. Picture this with me. We have Olive, a lovely 69-year-old woman, comes in after a low impact fall. She slipped in the kitchen while whipping up her family's favorite pecan pie. She has a wrist fracture, some height loss over the years, her back hurts, and her DEXA scan shows a T score of negative 2.8. My dear Qusay, textbook osteoporosis, right?
Absolutely. Classic postmenopausal osteoporosis, low bone mass, plus structural plummeting. That combo makes bones fragile, so even minor trauma like a fall from a standing position can cause fractures.
Hmm. Now, before we talk about meds, let's cover some of the basics, because a strong comprehension requires a sturdy base. So, Qusay, what's actually happening in the bones?
The easiest way to go about is to think that the skeleton is like a 24/7 construction site. Two teams work there non-stop. Osteoclasts are the demolition crew. They break down old bones. Osteoblasts are the builders. They lay down new bones. I like to remember that osteoblasts do the opposite of what their name implies. They don't blast bones. In a healthy adult, they are balanced. But in osteoporosis, the demolition team is working overtime and the builders are basically on strike.
Now, if osteoclasts had a LinkedIn account, their skills section would just say demolition, chaos, and ruining your DEXA score. Why would osteoporosis occur after menopause, though? What is the relation there, Qusay?
Several reasons. After menopause, estrogen plummets, and estrogen normally keeps osteoclasts in check. On top of that, aging naturally reduces osteoblast activity, and factors like low calcium and vitamin D intake, sedentary lifestyle, smoking, alcohol, and long term steroid use all add to the problem. The result, bone becomes porous, fragile, and prone to fractures. Overactive demolishers plus strike builders equals brittle bones.
Now, meds step in to restore balance. Okay. There are three main classes: anti-resorptives, anabolic drugs, and supplements. Anti-resorptives slow down the demolition crew. They include bisphosphonates, estrogen, and SERMs like raloxifene, calcitonin, and denosumab. Anabolics boost the builders. We have teriparatide and romosozumab. And calcium plus vitamin D, those are the raw crude materials. You can't build strong bones without them.
Let's start with bisphosphonates, the osteoclast assassins. Bisphosphonates are powerful and dramatic. They mimic pyrophosphate, bind tightly to bone, and when osteoclasts chew on that bone, they swallow the drug and die.
Death by renovation? Harsh.
There are two types: non nitrogenous, which are rarely used, they got incorporated into toxic ATP analogs, causing osteoclast apoptosis, and nitrogenous bisphosphonates, our real stars. They inhibit FPPS, farnesyl pyrophosphate synthase, in the HMG-CoA pathway. That stops protein prenylation, which osteoclasts need to survive, so they die.
And what of dosing, dear Qusay?
Alendronate and risodronate are given daily or weekly. Ibandronate monthly, and zoledronate once a year VIV. They all must be taken on an empty stomach with water, and patients need to stay upright 30 to 60 minutes. Or else, hello, esophagitis.
And we need to remember jaw necrosis, the boogeyman of bisphosphonates.
Exactly. Especially with high dose IV therapy, the jaw remodels constantly, and anti-resorptive block that remodeling. Even minor trauma can cause osteonecrosis. Risk factors include dental procedures, poor oral hygiene, corticosteroid, and infection.
Next up, estrogen therapy.
Estrogen helps maintain bone density and can reduce fractures by up to 50%. It also improves menopausal symptoms, hot flashes, memory, mood, vaginal health, the whole lot. But there are long-term risks like breast cancer, endometrial cancer, especially if we are using unopposed estrogen therapy, stroke, and VTE, venous thromboembolism. Unopposed estrogen for more than 6 months increase endometrial cancer risk by tenfold, which is why adding progestin for 10 to 14 days per month facilitates the return of the risk to baseline. Only patients with a hysterectomy can use estrogen alone. Everyone else need combined therapy.
So you get the benefits, but you have to navigate the plot twists.
And moving on to raloxifene, a SERM agonist on bone and lipids, antagonist on uterus and breast. It raises bone mineral density by reducing osteoclast activity, lowers LDL, and avoid breast endometrial complications. Some side effects include hot flashes, leg cramps, and slightly increased VTE risk.
So basically, estrogen that knows its boundaries.
Pretty much. We also have calcitonin, which binds osteoclast receptors, inhibits activity, and reduces bone resorption. Salmon calcitonin is used in subcutaneous and intramuscular, mainly for acute vertebral fracture pain. It's not super potent, but helpful.
And denosumab is a synthetic OPG, also known as osteoprotegrin, right?
Right on. It binds rank L, preventing pre-osteoclasts from maturing. Less osteoclast activity equals less bone breakdown. We give it every 6 months, and the side effects include hypocalcemia, infections, jaw necrosis, and rebound fractures if stopped abruptly. But calcium and vitamin D must be optimized first and foremost.
Let's now go over anabolic drugs, which help us build new bones. First up, teriparatide, aka PTH, but let's make it bite-sized.
Normally, PTH is catabolic. Continuous exposure increases bone resorption. But if we give it once daily in low doses, it stimulates osteoblasts more than osteoclasts, activates IGF, and drives new bone formation. But side effects include nausea, leg cramps, and dizziness.
Daily micro PTH results in bone gain. On the other hand, continuous PTH results in bone loss. Now that's a double-edged sword.
And finally, romosozumab blocks sclerostin, which acts as a brake on bone formation, boosting bone growth. Side effects include arthralgia, headache, and injection reactions. With all of these medications, it's pretty much important to keep up with vitamin D supplements, as well as calcium. Or else, how can the builders build with no bricks? Without enough calcium, the body activates osteoclasts to maintain serum calcium. If we block osteoclast without calcium, we get hypocalcemia.
Fellow listeners, practice makes perfect. Get the word play there? Pair for PodBites? Get a bite in, folks, and let's get practicing to really drill that info in just like an osteoclast. Olive now has severe osteoporosis, so she is started on denosumab. Which of the following must be addressed before starting this medication to prevent one of its most important complications? A. Smoking cessation. B. Adequate calcium and vitamin D levels. C. History of hot flashes. D. Prior use of glucocorticoids. And last but not least, E. Risk of esophagitis.
And the correct answer is B. Denosumab inhibits rank L, reducing osteoclast activity. If calcium and vitamin D stores are low, the patient can develop severe hypocalcemia after starting treatment. Calcium and vitamin D must be corrected first.
In today's PodBites, we unpack the fascinating world of osteoporosis by imagining the skeleton as a non-stop construction site, with osteoclasts as the demolition crew, or the drillers, and osteoblasts as the builders. We learned how osteoporosis happens when demolition speeds up and building slows down, especially after menopause.
Then we tackled the medications, starting with anti-resorptives like bisphosphonates, estrogen therapy, SERMs, calcitonin, and denosumab, all of which slow down bone breakdown through different mechanisms. We also discussed anabolic drugs like teriparatide and romosozumab, which boost osteoblast activity and build fresh, strong bones. And of course, calcium plus vitamin D, the essential raw materials needed for any of these treatments to work safely and effectively.
Thanks for listening to PodBites. Stay curious, stay matcha loving, and may your bones stay dense and your osteoclasts humble. A low impact fall shouldn't break anything except maybe your pride and Qusay's love for matcha.
Bye, everyone.